Bonsoir et bienvenue. On behalf of the Montreal General Hospital Foundation, I'd like to thank all of you for being here tonight. As we look forward to an informative evening on cancer research, it's important to recognize the strong foundation and history that our current team has been built upon and thank key leaders such as Dr. David Mulder and Phil Gold. It's an honor to have Dr. Phil Gold with us tonight. In 1965, Dr. Gold co-discovered with Dr. Samuel Friedman the carcinoembryonic antigen, which resulted in a blood test used worldwide in the diagnosis and management of people with cancer. We're also grateful for the leadership, mentorship, advice, and guidance that Dr. David Mulder continues to provide in building our surgical oncology team at the Montreal General, including to Dr. Lorenzo Ferri, who you will hear from shortly. Medical research and the programs that you will hear about tonight are only possible with the important philanthropic investments from our generous supporters, sponsors, and partners. For the past few years, we had the pleasure of hosting our Soirée en Or Gala to celebrate our annual progress in our thoracic oncology program. Although we were unable to have an in-person event this year, we are so appreciative of our Gala committee who continue to support innovations in our thoracic oncology program. I wish to thank our board and our board emeritus of the Montreal General Hospital Foundation, many of whom are in attendance this evening. Tonight's event will begin with a welcome from two of our co-chairs, Brenda and Samuel Gwartz. We will then have a presentation from Dr. Lorenzo Ferri, followed by a question and answer period. You will notice on the bottom of your screen a chat button. Please use this feature to ask any questions you may have. Bien que cette soirée se déroule principalement en anglais, notre équipe est bilingue, alors soyez bien à l'aise de poser vos questions en français. Tonight's event will finish with closing remarks from our other co-chairs, Evelyn Weitzer and Lawrence Batch. I want to thank our co-chairs of Brenda, Samuel, Evelyn, and Lawrence for their leadership and engagement for this event and their generous investments in our thoracic oncology program. Enjoy the evening, and please join me in welcoming Brenda and Samuel Gwartz.
Thank you, Jean-Guy. On behalf of my wife, Brenda, and our wonderful co-chairs, Evelyn Weitzer and Lawrence Batch, I want to thank you all for joining us for this fireside chat with Dr. Ferri on personalized cancer care research, which we hope will be most enjoyable and informative for you. I want to also thank each and every one of you for your support of Dr. Ferri's important cancer research work at the Montreal General, to which he brings much innovative thinking. There's much to say about Dr. Ferri.
I bet. Thank you, Sam. But if I were to say all there was to say about Dr. Ferri, I'd need to take up all the remaining time of this evening. So allow me a very shortened introduction. Dr. Lorenzo Ferri was born in the UK, but moved to Cambridge, Massachusetts at a young age. Dr. Ferri came to McGill to study genetics and has been in Montreal ever since, graduating with a BSc, a medical degree, an MD, a master's degree, and PhD. Dr. Ferri also went to Hong Kong and Toronto for specialized fellowships in esophageal cancer surgery. Lorenzo Ferri is the David S. Mulder Chair in Surgery, as well as a clinical scientist in the departments of surgery and oncology, specializing in the management of complex malignancies of the foregut. He heads the McGill University Program of Upper GI Cancer. Through this, he has spearheaded numerous initiatives designed to improve outcomes in gastric and esophageal cancer through excellent surgical skills, clinical scientific research, and individualized patient care. He established the McGill University Foregut Malignancy Research Group, a multidisciplinary collection of researchers and clinicians in the field of gastric and esophageal cancer. He's the first physician in Canada to introduce a novel technique of removing early cancers of the esophagus through endoscopic techniques, which has really improved the quality of patient recovery. And he's now been invited throughout North America to speak on this method. In addition, he has supervised many research as well as surgical fellows and research teams, trainees, and is a true mentor and role model to them. He has authored and co-authored over 120 articles in peer-reviewed journals. Dr. Ferry is the recipient of numerous peer-reviewed grants, including from the Canadian Institute of Health Research and the Canadian Cancer Society for his work in, of course, cancer progress and metastasis. In 2019, Dr. Ferry was part of an international team of scientists who received the Cancer Research UK Grant Challenge, a 5-year grant to study inflammation associated with malignancies of the esophagus, and leads the largest and most important work package of this grant. He is a unique combination of surgeon and research scientist.
But for me, Dr. Ferry is more than a scientist. 5 years ago, he operated on me endoscopically for a dangerous cancer. And thank God, thank Dr. Ferry, I'm here tonight to share this event with you. I also want to thank Dr. Ferry for his humanity, his caring, and for being there for me as needed during this 5-year period. It is thus with great pleasure and is a great honor for me to call upon a great thoracic doctor, a great scientist, Dr. Lorenzo Ferry.
Well, thank you very much for the extremely kind introduction, Brenda and Samuel. I'm really, it's really heartfelt, and there's not much more I can say to top that. Maybe I should stop talking right now and just let you guys continue talking. But I do want to highlight today I'm going to be talking about sort of the evolution of how our program has built, and it really is a team effort. Although I'm the one speaking right now, I cannot take all the credit for everything that we've done and what we plan to do. It really is a team effort, and it's completely dependent on the remarkable individuals that we've been able to recruit to McGill, but also heavily dependent on you, on Brenda, Samuel, Evelyn, and Larry, as well as all of our donors to philanthropy, without whom we would not be able to even build where we are now. And we've been able to leverage those funds, your donations, to really go out and get significant support from the Canadian government, from the UK government, from the US government. So that seed funds that you provided, really, we're able to turn that into major grants. And that's what I hope to be able to show you how our division really is built on a foundation of research, and that foundation cannot even get off the ground unless we have support from the philanthropic community, like events like tonight. So I'm going to talk a little bit about the Division of Thoracic Surgery and where we've come. It has been McGill has a very long legacy. So I'm going to share my my presentation here and get started. So there's been a long legacy at McGill in thoracic surgery as being at the forefront in in clinical innovations that have driven the way we treat cancers of the chest. This is Edward Archibald. He was one of the pioneers over 100 years ago. He was the president of the American College of Surgeons and the American Surgical Association, and he did the first anatomical lung resection, which means he for cancer, which means he ligated the separate vessels and structures that go to the heart, go to the lung from the heart. And this is still the way we treat lung cancer today. I'm not sure if everyone saw the Crown, the first episode. This is exactly the same operation that occurred 2 decades after Edward Archibald pioneered that operation. So this is at the Royal Victoria Hospital. Dag Monroe at the Montreal Chest Hospital in 1965 performed the first lung transplant in Canada, and the first one to leave the hospital. This is him here doing some research on where he transplanted a sheep's lung into this nice Bessie here. and shows you that really research, this would not be possible without the foundation of research. Fraser Gerd and Norman Bethune, these are two pioneering surgeons from the 40s, 50s, and 60s, really pioneered the management of tuberculosis that has been used around the world. So there has been a strong legacy at McGill, at all the university hospitals, in thoracic surgery and driving clinical practice through medical innovation and research. So at the beginning and initially, thoracic surgery or chest surgery was performed in all the McGill hospitals. In fact, probably over 50 hospitals across Quebec. Pretty much every hospital that had a operating room had thoracic surgeons operating, or at least people doing thoracic surgery. We had within our own like 5-kilometer radius, we had the Royal Victoria Hospital, the Montreal Chest, St. Mary's, Jewish General Hospital, and Montreal General Hospital, all performing thoracic surgery. But everyone was doing a little bit here and there, and it's hard to really optimize patient care if the care is quite fragmented. So over the past several years, I've really tried to centralize the thoracic surgery, thoracic or lung and esophagus cancer care, in order to optimize patient outcomes and improve and sort of increase the expertise in one area, improve outcomes. That initially started before I was even in Montreal, where the Chest Hospital closed down their operating theater, and all those operations moved to the Montreal Royal Victoria Hospital. But this centralization just then occurred first by default, then by decree, ministerial decree, and finally by reputation. We'll go through that process. Basically through retirement of surgeons and at these three hospitals, St. Mary's, Royal Victoria Hospital, and Jewish General Hospital, the most recent being Nate Shaner, the incredible Nate Shaner of the Jewish General Hospital. All the thoracic surgery was then transferred over to the Montreal General Hospital over the past decade. So although we are at the Montreal General Hospital, we do provide care for the entire region. Then the centralization occurred by decree. Right when I became divisional director, the ministry started an initiative to really look at centralizing it across the province. And the province, according to the ministry, is divided into 4 administrative regions based on the university. And this great thing is McGill here. This is Laval. This is University of Montreal. And this is Sherbrooke. So they started this process in 2010. They had a recommendation that came out in 2011, 2013. We started to really centralize everything to the Montreal General Hospital. And by 2015, all thoracic surgery, lung cancer surgery, esophagus cancer surgery was centralized to one hospital for this region in its entirety. That's the Montreal General Hospital. So although we do provide care to the Montreal General Hospital, we do provide, really, in actuality, we are the province's hospital for this disease. Then came centralization due to reputation. As we've recruited more and more surgeons that have a specialized expertise in certain parts of lung and esophagus cancer, or chest cancers, or mesothelioma, or sarcomas, we've really started building up a referral base from physicians across the province. Over the past year, these are just a sample of all the hospitals that have sent patients for us to manage. And so we've had over 40 referring hospitals across Quebec within the past year referred to the Montreal General Hospital for surgery, primarily based on reputation in specialized areas such as rare malignancies, sarcomas, mesotheliomas, and esophageal cancer, and complex lung cancers. So we do get patients from across, really across the province, and we really are a provincial program, not just a regional Montreal program or the west side of Montreal program. We are a provincial program providing care for across the province. This has resulted in a significant, sort of exponential increase in the thoracic surgery volumes. If you look at the lung cancer, when I first came in here, we're doing around 150 resections. We've gone up to around 500 resections this past year. Same with the esophageal cancer resection, the stomach cancer resections. So this has become, over the past 4 years, really the highest volume program in Canada, based on the centralization process that we've really been working over the past decade. So this could not be possible without these incredibly 8 dedicated surgeons that we've been able to recruit. So as I mentioned, Dr. Mulder recruited me and Christian Serrois at the beginning in the middle of 2000. So Dr. Serrois came in 2003. I came 2 years later, 2005. So initially, for the first decade, it was just the 3 of us. Then over the past 5 years, we've really recruited out outstanding individuals who've gone to train across North America. Jonathan Cools, we recruited back to McGill from Sloan Kettering. Jonathan Spicer was the first recruit back from MD Anderson. Carmen Mueller from Toronto. Matt Rousseau did his training in Stanford, and the most recent is Sarah Najma, who came in just this past year from Duke University. So that increased volume is really be driven by these 8 really strong surgeons, and I feel blessed to be working with each and every one of them. And everything that we do is based really on their strong effort. So we find that our clinical innovation, not only centralization, but after centralization, we really had to do clinical innovation to drive these improved outcomes and increase efficiencies in thoracic surgery. So we recognize that although we recruit all these people, the government's not really giving us any more resources. There really aren't. So we have to do more with less, or the same, if you will. What we've done is over the past 10 years, we've really increased, becoming Canada's largest program for minimally invasive surgery. So small keyhole incision for lung surgery. Beforehand, you used to do a 30 centimeter incision. Now we do most of our operations of small incisions, and that includes also esophagectomy. We're the first program in Canada to do the minimally or laparoscopic esophagectomies, and we still have the highest volumes in North America for this procedure. And same thing with enhanced recovery. This is a new process where if we only have a certain number of beds, we have to make sure the patients recover quickly and feel like they've improved, so they feel comfortable enough to go home. And our length of stay after lung cancer surgery is amongst the lowest in North America. This is the average for North America, around 4 days. We're half that. Same thing with esophageal cancer. We're 30% less based on the concept of enhanced recovery. That's really been, we're very fortunate to be at the Montreal General Hospital, where Leanne Feldman and Franco Carli are really the world pioneers in this concept of enhanced recovery, or improving people's outcomes through nutrition and exercise and anxiety coping. So we're fortunate to take advantage of, our patients can take advantage of this these incredible pioneering work of these 2 outstanding physicians at the Montreal General. So research really has maintained a central position in the division of thoracic surgery, even for the past 100 years. And currently we have 2 main streams. One is the clinical research and trials, which all of our members participated in. It's supported by quality and clinical research staff, which is funded entirely by philanthropy. And this allows us to do this clinical research in the form of clinical trials, novel chemotherapy agents. Even though we're surgeons, we've taken a leadership position in this area of chemotherapy and immunotherapy for lung and esophagus cancer. Indeed, Dr. Spicer recruited the first patient to the first trial in immunotherapy prior to surgery in the world, and he's one of we like to consider him one of the leaders in this area. In addition, we've had a strong fundamental and translational research lab. We are fortunate to recruit over the past 4 years 2 outstanding basic scientists, Sven Bailey and Vina Sangwan, to join our group. 2 other additional researchers. We have positions are to be recruited the next year to 2 years. We're supported by incredible research staff. When I first started, there was 1, Betty Giannis. She is my technician here, and now we're over 25. So we've really expanded this exponentially. This is where I think that we've really have made the greatest impact. So our research laboratories are based on 2 different sites. One at the Royal Victoria Hospital, is really a basic science lab, where we're looking at how cancer spread and how we can break down those the signals that make cancer spread, and also how to break down the signals between immune cells and cancer cells that make them more effective, and how we can design new therapies by breaking this concept down. This is again working with cells and mice. Is very, very basic science lab. Whereas the Montreal General Hospital, thanks to the initial seed funds provided by Evelyn Weitzer and Larry Vatch, we built a translational science laboratory, which is really to be close to where we do our scopes and where we do an operations, because it's dependent on using live human tissues and tumors, where we can break them down and restudy them and try to find new therapies for them. So this is where we really expanded over the past 3 or 4 years, and that's where the funds are heavily needed. So what we're trying to do with the Translational Research Lab, as well as the Basic Science Lab, is really try to challenge the traditional treatment of cancer. So traditionally, up until the 1990s, from the beginning of the 1960s, when chemotherapy was first designed until still currently today, treatment was based on what organ the cancer is coming from, and we basically had a trial and error method to chemotherapy. Someone who had a breast cancer would get breast cancer type chemotherapy. You wouldn't know if it worked. You would give it for 3-4 months, do another scan, see if it worked. If it doesn't work, you got to change the treatment. So it's just a trial and error. So those past 4 months were basically ineffective. That person got all the side effects, but none of the benefit. So we want to be a little bit smarter. So something that we've been doing in the past, what we're doing currently, a minority of patients, but we're still doing currently, is looking at the molecular changes in cancer care. And that is really looking at how genomic mutations can direct treatment. So currently we're doing, we can look at the mutations of certain cancers, and it gives us a laundry list of drugs that may or may not work based on those mutations. And this is a Foundation One medicine, is where you can send your patient's tumor to a company in the States. They look at what mutations are increased. And again, they'll still give you a laundry list of maybe 5 or 10 different drugs that may or may not work based on the mutations, but it's still a trial and error method. So we want to move beyond this. We want to take this to a different field, particularly for thoracic cancers. So one way we look at it is, listen, if someone has a bacterial infection, we don't treat things like that. What we do, if someone has a suspected pneumonia, we ask them to give a sample. They give a sputum sample. We grow that sputum sample out on a petri dish and see what bacteria are growing. And then we test which drugs, after growing it out on a petri dish. You put a whole different bunch of drugs here and see which ones work. Then, for example, this one here seems to have killed off a lot of the bacteria, where this one hasn't killed off at all. So we would choose this drug to treat that patient. That's how we treat a typical urinary tract infection and pneumonia. Okay, can we use this for cancer? And that's a concept we're trying to do. What was holding us up beforehand is we did not have the tools in order to grow cancer cells reliably outside the body in a way that replicates what's happening inside the body. So that brings me to the concept of the McGill Biobank for thoracic cancers, and using this as a tool to understand how cancers respond to treatment, and maybe we can do it to actually figure out how to treat the cancer. This is something we started when I first came back to McGill in 2005. And basically, when we take a tumor out of the patient, we analyze it, but we also take a portion of that so we can look at all the parts of a cancer, break it down to bits and pieces, and understand them a little bit better. But also, we're able to take the live cells, just like we do the bacteria. We can see if we can take it to the petri dish and determine it. So I'll show you a little video provided by John Cools, and hopefully this will work.
Hi, my name is Jonathan Cools-Lartigue, and I'm one of the thoracic surgeon scientists here at the Montreal General Hospital. We treat thoracic cancers. That includes cancers of the esophagus and the stomach. It includes lung cancer, and it includes cancers of the mediastinum, or the space between your lungs. These are devastating diseases. While we have some treatments that work, they're certainly not these dramatic responses that we were all hoping for. And so there's still a lot of work to be done. So one of the new things that we're doing here that's very exciting, it's very novel, that I don't think anyone else is doing, certainly not in Canada, is that at the time of surgery, when we operate on someone, we'll take their tissue and we'll grow it in the lab. And that's something that's called a patient-derived organoid. And the thought behind a patient-derived organoid is that it comes from this person and it effectively recapitulates the cancer that they have. So it's a very personalized therapy. Now, the benefit of having this is that we are able to establish a living biobank. What's nice about a living biobank is it's alive, just like your patient. And that gives us an opportunity to do a few things. We can check the genetics of a patient's cancer and see, do they have any mutations that we can target with drugs? So it informs your selection of drugs to treat that patient. But even more exciting is we can use that living biobank to test drugs, meaning we can take that person's cancer, grow it in a dish, and try several, 10, 15, 20, 30 drugs and see which ones work. What saves a lot of time. It saves the person a lot of potential suffering because you don't have to go through toxic drugs that may or may not work. At least you've educated your decision on which drug to try in that person. The biggest benefit of this kind of research, often when we consent patients in the clinic for research, we tell them, this probably won't help you, but it might help someone down the line. What's nice about this line of research is we can say we're doing this so that we can help you potentially. And I find that very exciting.
So as Dr. Cools mentioned, that we really try to build this living biobank. Sorry, what's going on here?
The human digest.
That didn't work. So what we really try to do is build these tools to allow us to not only study this cancer, but also to potentially, if we can get everything lined up correctly, to treat patients that were to study a cancer in someone who's actually undergoing treatment. So maybe we can impact the way they're treated. So we built a very large biobank: esophagus, lung, mesothelioma, chest sarcomas, and thymic cancers. And I would say our esophageal cancer bank right now, the living bank using those live cells, is the largest in the world. This is really a testament to the team that we've been able to build, and the incredible scientists that we've recruited into our team. This is an example of how we can study outside the body. These are the organoids. There's these 3D constructs of a individual patient's cancer. This is someone's cancer, and we're growing outside the body. It's around 3,000 different cells in there. And we can give the drugs outside the body. And this patient here, the drug that we've given completely destroys it. This is like the Death Star. See, it explodes completely in response to the chemotherapy that we're given in the lab. Whereas this patient's tumor does shrink down a little bit, but does not quite shrink down and get destroyed completely. So outside the body, we know that this patient should continue getting the chemotherapy. It works. However, this one, maybe, because it doesn't respond as well, maybe we should consider changing the chemotherapy. So how do we change the chemotherapy? We talked about that a little bit earlier. One thing to do is when we take someone's tumor from the operating theater, because the lab is right upstairs, one floor above the operating theaters, we can take this tumor rapidly and process it. We can do DNA sequencing and search for mutations. And we can also build those organoids, create those organoids at the same time. Then we find out from this sequencing what drugs might work, and we could test those drugs precisely outside the body, just like we did with bacteria. And then that will hopefully identify the biologic agents and the antibodies that will actually work in the person. This is something we're trying to do. This pipeline we're trying to generate in a timely fashion, so it makes it different to the patients. And we know that unfortunately the tumors are much more. Although that is a great advance, we know that tumors are much more than just cancer cells. This is an example, a schematic of a tumor. We have all these different tumor cells, but in there you can also see these are blood vessels. There are structural cells right here. There are immune cells. So these are all make up a tumor, and we know that these structural cells, these other immune cells, can help determine how a cancer acts biologically. So in order to get a really accurate measure of how a drug's going to work, we need to put them all combined into one area. And can we do this now outside the body? And 3 years ago, I would say no. But over the past couple of years, we worked with some of our collaborators around the world, and particularly in Boston. This is the team that we worked with our Cancer Research UK grant, which shows what we're trying to do is recreate all those cells within an organ chip, like a small USB-sized chip, where we put all those different cell types in the chip, and it allows you to breathe and gives you some motion, and that gives you a real physiological. Basically, take an organ, put it in a chip, and test the drugs on that. That is the most accurate way of determining whether someone's going to respond. So I'll show you another short video from our collaborators down in Boston describing this.
The first step is that we really have to be true to the human body. We call these organ chips. Each chip is engineered to create the right environment for cells to feel like they're within the human body.
The chips provide the mechanical forces that are critical for the cells. When you breathe in and out, you can feel the forces that the cells experience as your lungs expand and relax. There is also the flow of blood that creates a dynamic environment and brings in nutrients and takes away waste products. All of this taken together allows us to recreate the microenvironment that the cells need so that they can behave just like they do in our human body.
So what we're trying to do here is to recreate the entire a patient's tumor within this organ chip. We have purchased this, although my collaborator at Harvard has licensed this to a company. We purchased that equipment when we're the first lab in the world actually trying to recreate a person's tumor within these organ chips. Most labs who are looking at this really look at it just to study how these cells react. They use sort of cells off the shelf that you can order. We're using an actual patient's tumor, so where we take out the immune cells, we take out their cancer cells, their blood vessel cells from that tumor, recreate it in the organ, and then allows us to test really which drugs work. So this is an example of the first chip that we're working with Harvard, with my colleague down at Donningborough at Harvard. And so he's already started to develop this. We have this equipment up and running in Montreal, and we hope to be able to recreate a patient's tumor in a realistic timeline to allow us to really study how those respond, how drugs respond, and which drug is best for a person. So we're really trying to challenge the way the traditional treatment of cancer care. This is what we want to get to. We want to get to the point where we not only know the genomic mutations that the patient has, but we actually test the drugs that attack these mutations outside the body before giving to the patient. Because even if we just do this, it's still just a trial and error method. So we want to get rid of the guessing game and really try to find a way to have a true precision oncology approach for cancers. So where are we in February 2021? So 3 years ago, we established the Weitzer and Vatch lab at the Montreal General Hospital as a outreach of our main lab at the Royal Victoria Hospital. It's taken us 3 years to really establish the pipeline of getting the patient tissue to the translational lab, either from the endoscopy suite like this or the operating room, where we then process the tissue, break down the tumors into its different parts. We've optimized the organ generation protocol for these cancers. Some are easier to do than others, but we have to identify each and every different type of cancers comes with its own culture techniques. This takes quite a lot of time. That's why a lot of labs are not doing it, because they have not built this pipeline. We've secured a sequencing and analysis protocol. We have recruited a computational biologist who's an expert in reading how mutations are driving cancer. We've purchased a high throughput drug testing platform, and we've developing this so that we can look at which drugs work. And finally, the organ chip program has just been initiated. The equipment has been installed last 2 months ago, and we've started to try to build these organ chips to allow us to test which drug works the best in patients. So our goal is really to try to complete this entire process in a clinically relevant timeline that makes a difference to the patient. So that means if I have a biopsy, someone has a new diagnosis of a tumor, we do a biopsy, then within 4 weeks to 6 weeks, if we can get this whole process down in 4 to 6 weeks, we'll have a drug that we know works for that patient. And that's going to be a game changer. That's what we really want to do. And that's where that's our goal in order to try to get this down to something that's not just a scientific interest, but as Dr. Kuhl said, can really make a difference for patients. So although a lot has changed over the past century from McGill thoracic surgery, when we're doing the open incisions here, now we're doing microscopic, laparoscopic incisions here, throughout the entire history of McGill thoracic surgery, what has not changed is our commitment to scientific discovery and clinical innovation to help our patients. Thank you very much.
Thank you, Dr. Ferry, for that great talk. It's an exciting time to be involved in the field. So I'd like to thank you for that. We have some time now for questions. So if anyone would like to ask a question, I'd just like to direct you to the chat at the bottom of your Zoom window. We'll try and get to as many questions as we can tonight. If we can't get to you tonight, we will respond to you in the coming days. So please feel free. In the interim, one of our first questions came into us via email. It came in from one of our co-chairs, Samuel Wirtz. So this is for Dr. Ferry. You're using the organ chip to test cancer drugs and treatment. How is this different than what's being done elsewhere? And how are those chips usually used?
Well, that's an excellent point. I think ultimately these chips there are many different types of organ chips out there. I mean, there are ones that we've developed here in the past. I mean, the concept of an organ chip is just trying to get at least 2 cells growing together. But what's different about this chip? This chip is, again, developed by one of my collaborators. It really incorporates the mechanical flow and stresses that people have whenever you take a breath and your tissues stretch and close. So this is a really physiological relevant chip. It has been right now. It's a very new technology, and it's really being used by most labs around the world to study biology and how cancer or any disease interacts with different cells. What no one has been able to get, to my knowledge, no one has been able to get it to the point where we actually test drugs for patient care. And that's the difference here. What's taken us, the reason why it hasn't been done is that it's very hard to get that pipeline we described of having an operating room right next to our lab right next to the operating room, and getting the pipeline where the tissue is dissected out within minutes. And then having that passed off to the organ chip. That process is quite laborious, and the only reason why I've been able to do it is because of the philanthropic community here in Montreal. Again, we're not ready to roll this out just yet, but I do think that once we have the process set up, our goal is to get it so it really makes it in a timeline that makes it different to patients. So it needs to be in weeks, and not months and months and months. It won't do anyone good if it takes us a year to develop this.
Great. Let me just go through the list here. I got a big one. This is for all of us. So anyone who wants to try and answer this one, jump in. When surgery isn't an option, do you think TILs, so tumor infiltrating lymphocytes, are one of the most exciting opportunities? mRNA is in the news significantly because of COVID, but most of these companies have cancer programs. Do you think mRNA would be a good potential therapy as a cancer vaccine? And do you think the future could focus on proteomics or protein degradation as opposed to genomics for cancer care? In a recent study, FMTs were shown to provide some benefit for cancer therapy. Do you think microbiome therapeutics could be helpful since FMTs aren't scalable? Dr. Ferry, I'll let you have the first crack at that one.
Oh my God. I think you've written a whole grant in there. I wish I could say. What I will say, I agree completely with that question, in that if we just concentrate on the cancer cells, I mean the cells, the glands, most of our cancers are glandular in origin. If we just concentrate on those cells and forget and don't look at the structure cells, the blood cells, the immune cells, then we're not going to get the whole story. And that's the problem that we've done in the past 65 years of cancer research. I think everyone's, if anyone's read The Immortal Life of Henrietta Lacks, it's sort of describes how we've studied cancer. We just took out those cancer cells and studied them in the lab without putting all the other ones. And that's where the organ chip allows us to look at all those different cells types together. Allows us to look at the TILs, allows us to look, we can add microbiome to the organ chip and determine whether or not that impacts how someone responds to a treatment. We know it's important, but we haven't had the tools to study it yet. I don't know, John, do you want to follow up on that at all? Or?
Yeah, I think that's it's an excellent point, and I think one of the advantages of the organ chip is it's not limited to any one form of therapy or another. If we can recapitulate the organ as a whole, then we can test any therapeutic approach. And in fact, one of our biggest interests is looking at the role of immunotherapy and being able to model an intact immune system in this sort of setup. So that's critical. And as for the comment on microbiome, that's a huge hot topic right now. It's kind of exploding at the present time. But certainly if we can model an immune system, we can look at the effect of the microbiome. And that's something that we certainly have in mind. So I think that answers some of that question. Okay, I'll move on to the next one. Have we tried this, or have you tried this successfully on anyone yet? So
John, maybe you can comment on that.
Yeah, I can comment. So we have used this approach on one patient so far. We did exactly what was described in the talk and in the video. Is we collected tissue at the time of the first operation, the curative intent operation. And patient did very well for a while, but in the meantime, we modeled his cancer, studied his genetic mutations, and looked at, we performed a drug screen that identified some target drugs that seemed to show a very good therapeutic benefit in the lab. And when that individual did eventually have their cancer recur, unfortunately, we were able to use that drug for them. Now, like everything in science, I wish it was as simple as some of these talks show, you know, simple, right? Test the drug, give it to that person and cure. Unfortunately, it doesn't always work that way. And I think what's important to highlight is while the pipeline is extremely important for driving discovery and driving the development of new drugs, this pipeline also allows us to take a step back. So unfortunately, this particular individual succumbed to his disease, but we were able to secure tissue post-mortem, what's called a rapid autopsy. And that allows us to secure more live tissue and to try and understand why did our approach fail. Most of science, I would say 99%, is often failure. And I think being able to learn from our mistakes and move forward is extremely important. And that's something that the approach that you heard described here has allowed us to do. So more updates in the future to come. I don't know, Dr. Fair, if you have anything to add. I think that's where we stand on it right now.
Yeah, I think that's it. We have looked at, we're really trying to optimize the pipeline and try to optimize the timeline that we're able to get from biopsy to from genomic sequencing or the cells, test the cells based on the genomic sequencing and have something ready. I think we're going to have our next step is really to do a trial where outside the organ chip, because organ chip is a separate issue, where we actually do that, and rather than using traditional care, which is trial and error method, we do an actual we treat the patient based on the drug, and that's our next step. We have the ability to do this now. The only stumbling block that we seem to have is really regulatory from Health Canada about access to those drugs. I think, John, you had some difficulty getting your patient access to those drugs because they're not designed for that specific purpose. And that's where we have to work with Health Canada.
Great. I'll move on to the next question from Patricia Forbes. My husband died of cancer at age 64, his uncle at 96 with the same diagnosis, and his father at 86 with laryngeal cancer. The advances in treatment are wonderful, but what research is being done in hereditary cancer?
Oh, I agree with you. I think that's hereditary cancers are an important point. And what we know is that pretty much all cancers are genetic in origin. They have some genes in the cancer drive it, but there are some cancers that have inherited genetic mutations that make cancers more aggressive or more likely to appear. I would say that over the past 50 years, most of our efforts have been towards genetic causes of cancers. We're still a long way to go, but there's we can think about the story of the BRCA gene, the BRCA gene, as I won't say a success story, but at least a understanding of how hereditary cancers, how we can understand them and how we can use that for treatment and management of patients. But I agree, we have a long way to go. But we do have quite a bit of scientists at McGill who are concentrating primarily on the genetic causes of cancer.
Great. The next question is from Jonathan Ani. So is this organ chip program only being tested on thoracic cancer patients? And if so, when will it be used to treat all forms of cancer?
Oh my God. Jonathan, that's a great question. We are going to do what we can do here. Our expertise and our ability to generate these cells and study the cells are based on thoracic cancers. I know there's a group at UCLA who's looking at colon cancer using the organ chip. I think they're looking at more for scientific discovery rather than therapy for treatment. But I do think it's going to take us a couple of years to get this off the ground where we feel comfortable to base treatment based on the organ chip. I think we have a few steps to go beforehand. We do what we know how to do. But our goal is to really get this working for one cancer type. And the one that we have the most tools to do that is with esophagus cancer, because we have a very large biobank for that. But once we have that expertise, I plan to roll this out for the entire Montreal community. If there anyone who will be willing to help and share this technology and expertise with the entire Montreal community in order to help whatever cancer someone wants to investigate and see if they can treat this.
Our next question comes from Stephanie Riddell. So Dr. Ferry, Dr. Cools, how long does it take from taking tissue from the patient to testing it in the organ chip? Is this a matter of days or weeks or months?
Yeah, it usually takes around 2 weeks to generate the organoids, so the small cells, and that's around the same time it takes us to do the sequencing. Well, probably 2.5 to 3 weeks. Our goal is to get it down to around a 4-week period where we get that information from the sequencing, then test the drug. So we can do it. I think we can do it within 4 to 6 weeks. Not the organ chip, but the rest of the process, the organoids. We can do that probably 4 to 6 weeks.
So we have another question from Francis. Is this innovation being tested in other cancers? I think just to add on top of what Dr. Ferry said earlier, I think the benefit of this approach is we're really recreating an organ on a chip, which is essentially what cancers are. You know, there are a multitude of different cells, and so this opens up a lot of pathways to discovery. You've heard what we discussed today, and that's the plan, but this is such a versatile technique that I think it's going to lend itself and open up a lot of research avenues as things go forward. I think we're going to learn a lot as we implement this more and more down the road. So I certainly think the potential to implement this in other cancers is there, but there's obviously a bit of a learning curve as we get this technology off the ground. Anyone else have any other questions? As we move forward, or before we move forward? I think that's it. So if anything comes to mind, feel free to send your questions along. And as I said, we'll get back to you within the coming days. If that's it, then I'd like to introduce our co-chairs, Evelyn Weitzer and Lawrence Vatch, for their closing remarks.
I think we need to get off mute there,
You
unfortunately.
have to unmute.
There we go. Did we do that? Unmute.
No, you guys unmuted for a second and then muted again.
There we go. All right, here we go. Hello, good evening. A little glitch there. First of all, we'd like to thank Dr. Ferry and Dr. Cools for an amazing presentation. 100 years of history, what's happening yesterday, what happened yesterday, what's happening today, what's happening tomorrow. Very, very excellent presentation. I think it's important to remember that the pioneering research being done now by Dr. Ferry and his amazing team would not be possible without philanthropy. Thanks to all of our sponsors and donors, we have raised this year over $365,000 in only 2 months. This is an outstanding accomplishment, and without a big party even. Donation to support thoracic oncology research are always welcome. If you haven't already done so, we encourage you to make your donation before March 31st for your chance to win a $5,000 gift card and consultation compliments of Mobilia. Regardless of the amount, everyone who donates will have a chance to win. The winner will be announced on April 1st on codelife.ca website and the Montreal General Hospital social media platforms. Thank you again for joining us this evening. Have a great evening. Stay healthy and stay safe. Good night. Jean-Guy? Somebody? No?
Yeah, no, again, thank you to everybody. It's fantastic to see the passion, Dr. Ferry and the team. So thank you everyone for your support. Thank you for being here. And thank you to our co-chairs for your leadership and generosity. And thank you to everyone who attended tonight attentively. It's great to see the passion from the thoracic team. Thank you for everything that you do in the community. And thank you everyone for your support. Be well.
I'd like to again want to thank everyone, Samuel and Brenda Gewirtz and Evelyn Weitzer and Larry Vatch for your incredible support and running and co-chairing this event, and for your as well as all the other supporters over the past years to our the Montreal General Hospital and our lab. As mentioned, this could not be done without the incredible support of all our of our scientists and our collaborators and students and all the surgeons. Once again, thanks everyone. This has really been outstanding. I wish we can do this in person. Hopefully, this November we can redo this our gala, and hope to see everyone in person. Bye bye.
Thank you, everyone.